Accountability is one of those words that sounds simple until you try to practice it. We use it constantly in this field. We tell our clients they need to be accountable. We write it into transparency contracts, into disclosure agreements, into recovery plans. But here's what doesn't get said often enough. In the treatment of sexual addiction and betrayal trauma, accountability isn't something we ask only of the client. It's something the work asks of us, and it cuts in two directions at the same time. So let me lay out 5 non-negotiables, 5 places where for a clinician doing this work, it depends isn't an acceptable answer. These aren't 5 separate rules. They're one stance seen from 5 angles. 1, treat the wound, not just the behavior. Sobriety is just the floor. It's not the building. A client can string together a year of abstinence and have changed nothing about what drove the behavior in the first place. The nurturance that never came, the intimacy he never learned, the shame he's been running from his whole life. If all we've done is stop the behavior, we've managed a symptom and called it recovery. The behavior was always a solution to something. Take it away without addressing what it was solving, and you've left a man white-knuckling the empty space where his coping used to be. That's not recovery. That's a relapse waiting for a bad week. Real accountability means we're responsible to the whole person, not to the number of days he stayed sober. 2, hold your client accountable without shaming him. And this is a hard one. Here's the trap. Shame isn't incidental to compulsive sexual behavior. For many men, shame is the payoff, the very thing the cycle is built to produce and then discharge. So when clinicians meet that disclosure with disgust, with moralizing, with that subtle hint of contempt, they think they're confronting the behavior, but contempt only pours in more shame, and shame is the fuel the behavior runs on. They aren't hitting the brake, they're pressing the gas. Accountability and shame aren't the same act. Accountability says, you did this and you need to face it and own it. Shame says, you are this. One holds a man responsible for what he did. The other tells him what he is. The first can heal. The second is the wound, the shame that drove the behavior to begin with. Holding the first without inducing the second is a clinical skill, and getting it wrong deepens the exact thing you are there to treat. 3, don't pathologize the partner. When the betrayed partner walks in, she may be enraged, checking his phone at 2 a.m, swinging between fury and collapse. For decades, our field had a name for that. We called it codependency. We treated her reactions as the pathology to be corrected. That was wrong. What you're seeing is trauma, betrayal trauma. Her hypervigilance is a nervous system doing exactly what a traumatized nervous system does. The device checking isn't a character defect. It's a woman trying to find ground under her feet after the floor gave way. Hold that understanding, and everything downstream changes. You stop handing her the recovery to manage. You stop treating her grief as a symptom, and you keep discovery and disclosure distinct. Discovery is when she finds out on her own, what she finds out on her own. She catches him. She stumbles onto the truth. Disclosure is when he sits down and tells her himself deliberately and with preparation built around it. They can look alike from the outside, but they leave different wounds. When the addict is discovered, he comes in with rage and defensiveness. When he discloses, he comes in with grief and guilt. Treat one as if it were the other, and you've mistimed every step that comes after. 4, stay accountable for what the work activates in you. This material reaches in and touches the clinician. It has to. You'd be made of stone if it didn't. Disgust at the details. Fascination you're not proud of. Over-identification with the addict or with the partner. The urge to rescue. The quiet pull to take a side. None of that stays out of the room unless you're watching for it. So watch for it. And you don't watch alone. Few subjects reach into a clinician the way this one does. Hearing the details of somebody's sexual life and compulsions can stir things you didn't expect to feel and touch your own history in ways you didn't see coming. This isn't a failing. It's what the material does to almost anyone who sits with it. And those are the reactions hardest to catch in yourself, which is the whole point of supervision and consultation. They make visible what you can't see on your own before it subtly steers the work. Number 5, work within your competence and keep training. This is specialized work. The framework that makes sense of it, the arc of the partner's recovery, the slow architecture of rebuilding trust in a couple. These are learned, not improvised. You didn't arrive already knowing them, and neither did any of us. So you're honest about the extent of your competence. You refer out when a case is past it. And while you're in it, you keep learning because this field keeps moving. And the clinician who stopped studying 10 years ago is working from a map that no longer matches the territory. That's not a knock. Specialized work demands specialized training, and it demands it continuously and updated continuously. So 5 non-negotiables. Treat the wound, not just the behavior. Hold him accountable without shaming him. Don't pathologize the partner. Stay accountable for what the work stirs in you, and work within your competence while you keep building it. Look closely and you'll see they're not 5 rules at all. They're 1. Every one of them turns on the same truth. In this work, accountability always cuts in 2 directions at once. You hold the client to the truth, and you hold yourself to the standard that makes holding therapeutic instead of punitive. The day we forget the second direction is the day the first one stops healing anyone. That's the standard. It isn't negotiable, and it's the whole job. I wish you well.